Good morning, everybody. I want first to welcome those people who are looking at us online. So very much welcome to this meeting, and those who did the walk to come here early in the morning. Very much welcome. This is rather looking like a kind of family meeting, so we can have a little bit more informal interaction, but that can only contribute to the quality, and as I always say, it's not the quantity but the quality that counts, and I'm sure that we will have a very fruitful interaction. Thanks for being here with us. The expert panel on effective ways of investing in health, as you know, during the last 6 years has produced, I think, 19 opinions, if we count it, on different topics. So this is number 19. And we are very happy that we finish our second cycle, because we work in cycles of 3 years, with a very important topic, which is the health promotion and health promoting health systems. I suggest that for today we approach it this way, that first of all we will listen to the introduction, and it is our rapporteur, Professor Margaret Berry from Galway, that is going to lead us through this document. And the aim then of the exercise is that we have as much as possible feedback and comments from your sides on the draft opinion, that by the way was already on our website, in order that we have your ideas and that we can see then how we can improve, correct, optimize our document. Our document that has the ambition to serve in preparation of policy meeting at different levels, the level of the Commission, the Parliament, but also the Member States and the regions. The hearing will be web streamed. Whenever you intervene, please present yourself shortly, so that not only for the report but also for those who are following abroad, they can hear and see who you are. So if you agree with this procedure, then I suggest that we listen to Professor Margaret Berry, who will lead us through the opinion document. Is that okay for you? So, Margaret, you've got the floor.
Thank you very much, and good morning, everybody, and thank you all for joining us. As Jan said, here is a picture of the expert panel. I actually think there are 1 or 2 people missing on this photograph, but anyway, that's the group of us who were involved in the second stage of the panel, and many of those members contributed to the production of this opinion. Professor Jan de Masner was the chair, I was the rapporteur. You can see all the names listed here, members of the panel who contributed, and I also want to acknowledge the contribution of external experts, Professor Timo Stahl from Finland and Dr. Selina Rajan from the London School of Hygiene and Tropical Medicine, who also contributed. So what I want to do in this presentation is to try and give you an overview and a condensation, if you like, of what's in the report, and the full report is online and you can read that. So it will give you really the essence of what's in the document, so I'll take you through it. So first of all, starting with the mandate that we got, what we were asked to do, and the terms of reference for that. So firstly, we were asked to explore what are the mechanisms for strengthening the implementation of health promotion within health systems. So looking at how health systems can more effectively incorporate health promotion, and what policies in place need to be, particularly around health in all policies. What needs to be in place to make that a reality. As public health and primary health care are operating in a more integrated way, to look at how this joint approach could contribute to greater integration and implementation of health promotion from the point of view of improving health literacy, its functioning within primary care, and also linked to social care. And the final point was to look at what are the success factors for further integration from a conceptual, an organisational and a financing point of view. So we've tried to address these issues in the course of the opinion. So starting, we thought it was important to just kind of start and look at, have a clear understanding of health promotion, where it sits, and also from a conceptual and policy framework point of view. I think that was important to lay that out and then look at how we can effectively integrate that. So the first thing to say is that health promotion, of course, is a critical component of modern health systems, and it is necessary for ensuring healthy lives and maximising health potential for all, ensuring that no one is left behind. So it's very much a universal approach. It reframes the challenge of improving population health and well-being since its emergence in the 1980s, because its focus is on how do we promote and protect good health at a population level. Therefore, it embraces a positive definition of health and introduced a new and broader understanding of the factors that determine health and how those determinants can be addressed. So this brought, if you like, a shift in focus from primarily looking at the treatment and prevention of disease to now also look at how we can promote population health and well-being. So that was quite a significant shift. The main conceptual framework we use is we go back to the Ottawa Charter for Health Promotion, introduced by WHO in 1986, which defined health promotion as the process of enabling people to increase control over and improve their own health. So keywords there, it's a process, it's about increasing control, and it's about health. And the Ottawa Charter embraced a socio-ecological model of health, seeing us shift from a predominant biomedical model to looking at social ecology, where people live their lives. And it provided a blueprint really for integrated action. So this was a paradigm change in thinking about health, and I've put health in bold again to emphasize that, and stated very clearly that health is more than the absence of disease. And it really brought up the question, it asked the question, where is health created? Okay, and how can we promote the greatest health gains for the greatest number of people? Right. So that's the orientation that it heralded. This requires a multidisciplinary knowledge and skills base that extends beyond the traditional healthcare approach. So it says we not only need to look at individual behaviours, but we also need to consider broader social and policy strategies across different sectors if we really are going to address this. So this is a graphic really representing the Ottawa Charter, a systems-based approach which looks not only at the level of the individual, but it looks at the individual in the context of their community, their environment, and the structural and policy factors that determine that. So that's why we talk about integrated action at each of the 5 areas: developing personal skills, strengthening community action, reorienting our health services towards promotion and prevention, creating supportive environments for health, and ensuring we have public policy that promotes good health. So these are the 5, and we need these to work together in a systems approach. That's the basic model that was put forward by the Ottawa Charter, underpinned by key principles. So the rationale, the reason why health promotion came around in the first place, I suppose that rationale is still, in fact, even more relevant still today. We are seeing changing patterns of health and the continuation and emergence of new and complex health problems, non-communicable diseases, addressing those, improving mental health, and also people living longer with multiple chronic conditions. So all of this presents quite a challenging picture. Also very important, addressing the social determinants of health inequities. Health inequities have grown. In many cases, they have not reduced, despite the improved kind of economic and social conditions in some countries, and looking at how we can do that. And health promotion here, the reason it came about was there was a recognition that, in fact, behavioural, social and environmental factors play a real part in shaping population health. They shape the environments people live in, and they shape the decisions and choices people can make. So we talk here about addressing the causes of the causes. The other argument is that for the sustainability of our health systems, because we have rising demands for expensive clinical treatments and healthcare, we have to look at what can turn the tap off. We've got rising NCDs, so we have to go back and say, how can we invest in prevention and health promotion, keeping people healthy in the first place? So this should be part of the continuum. The economic argument is also clear that there's a strong case in terms of the efficiency and the equity in our health systems systems, if we invest in health promotion, the health gains that can follow from that. And there's quite a lot of work emerging looking at improving long-term population health in a cost-effective way is possible through quality health promotion and primary prevention. The policy frameworks, be that at a global level or at a European level, we can see the Political Declaration on the Prevention and Control of NCDs, the WHO Global Action Plan on Mental Health. Both of these focus very much on cross-sectoral actions. This is embedded in all these policies. The Helsinki Statement on Health in All Policies, of course, was a key framework in terms of implementing a health in all policies approach at a country level. And we have Health 2020, again, our European policy framework, very much endorsing a kind of a cross-government and a cross-society for health and well-being. So we see common priorities and common recommendations for action, embracing a whole of government and a whole of society approach. And then, more recently, we have the Sustainable Development Goals by the UN, here ensuring that all human beings can fulfill their potential in dignity and in equality in a healthy environment. So health promotion is key to that endeavour. We have specifically Goal 3, looks at ensuring healthy lives and promoting well-being for all across all ages. And particularly Target 3.4, which again, it's interesting, for the first time it explicitly references mental health, Target 3.4, to promote mental health and well-being. And that was quite a significant inclusion in this document. But when we look at the other 16 SDGs, the majority of them in fact are important determinants of health, be that in terms of poverty, education, gender equality, a sustainable living environment. So these are the determinants. And this is reflected in the Shanghai Declaration on Promoting Health, and again, universal health coverage in terms of looking at universal health in a comprehensive way. So, I mean, just to go back, these policy frameworks and the SDGs, they provide an important, I suppose, new impetus to re-engage and reinvest in that full spectrum of health systems. So in terms of implementing health promotion, going from the frameworks to making it a reality, successive EU health policies and strategies have endorsed the need to invest in health promotion. But progress is very variable across the EU member states. Some countries have made a lot of progress, others less. The focus, I could say, is primarily still on curative and clinical care, as countries are still struggling with the delivery of that in many cases. We do know that there are cost-effective and feasible health promotional interventions available and that have been shown to make a real difference in terms of improving population health, reducing risks for illness, improving health and well-being, health literacy and health equity. So there is an evidence base that this works and that it's feasible to implement. However, there are still significant gaps in implementation. We see that in many countries there's a lack of political commitment and a lack of investment in developing health promotion systems and ensuring that there is sustainable financing mechanisms for this. In many countries, there's a lack of infrastructure around health promotion. Whose responsibility is it? Who's going to do it? Who's going to make it happen? So the organisational and the workforce capacity is not developed in many cases. So that was the first part of the opinion, where we laid out what is health promotion, where does it sit in, where does it come from. And then in the second part, we engaged in an exercise to say, well, look, what progress has achieved, like what barriers and what enablers are there in order to kind of advance progress. In this, we drew on the existing literature because there has been quite a bit written in terms of progress on health promotion since the Ottawa Charter in 1986, so 25 years on, 30 years on. And we drew on some of those papers that had made a kind of a critical reflection on that. Also on papers that looked at some of the issues around policy change in population health and health promotion, how difficult it is to get this on the policy agenda and keep it there. So we drew on those papers, and also the work of the Joint Action CRODIS Plus report, which recently did an overview of good practices, gaps and needs in health promotion and primary care across 21 EU countries. So that's kind of looking at what is the current state of play in relation to this. Most of these documents and publications talk about the need for a long-term strategic approach, that there isn't a quick fix on this. Okay, so we need a long-term view, and there needs to be also, it's quite clear, a focus on creating supportive environments for health, and avoiding what's termed lifestyle drift, where we just look at individual behaviour change but do not address the environments that influence that. So that's coming out clearly. And the other issue that comes out is that we need sustainable resourcing and capacity development for health promotion, because as we've seen in times of economic difficulty and austerity, this is the first area that will be cut in the budget. So how do we protect that? Okay, so as well as drawing on the literature among the panel, we had a kind of critical reflection and active discussion around this. And in terms of looking at the enablers for progress, we drew quite heavily on a position statement by the International Union for Health Promotion and Education on the system requirements for health promotion and primary prevention. They had outlined 10 system requirements, and so that informed some of our thinking around this as well. So just looking here at barriers and enablers, this is what we came up with, putting all that together. So starting maybe with the barriers. The first is at a conceptual level. I suppose here that the concept of health promotion is often poorly understood. Everybody thinks it's a good idea, we're familiar with it, but what does it actually mean? And what does it actually mean when we translate it into practice? So there seems to be a block around that. And I know this, in fact, from teaching our own postgraduate students. When they tell people, what are you doing? I'm doing a master's or a PhD in health promotion. Well, what is that? And I often say to them, you need to be able to explain that coherently to anybody who asks you. And it's something that people struggle with. So that, that conceptual clarity around what it is. Also, it lacks visibility, in terms of the larger health system approach, that it's not as high on the agenda. And it lacks public visibility as well. And also there are sometimes ethical issues around some of the health promotion strategies, be it in terms of like social marketing or very targeted behaviour change. People say, well, this is the nanny state intervening, telling people how to live their lives, what they can eat or cannot eat and what they should do. So there are kind of sometimes ethical arguments put forward as well, and these need to be addressed. In terms of policy and political barriers, we looked at institutional norms and practices at a policy level. And of course, these are very much still dominated by, the treatment of disease. That's, the immediacy of dealing with new and continuing health problems. So this is first on the agenda. And so where does health promotion and prevention find a space in relation to that? The medical model of health is still very dominant, and so therefore bringing in a more social model of health, a socio-ecological model is quite difficult. We have, of course, very powerful competing vested interests, be that in terms of hostile industries, tobacco, alcohol, and where we're looking at bringing about real societal change in relation to that. So these have deep pockets. Health promotion has a very broad scope. And often there is a diffusion of responsibility. So it's a big landscape in terms of health promotion and who is responsible. And so that there's often seen as a lack of accountability because of that. And that's a barrier. Lack of institutional structures and processes. And this is important around structures, both in terms of policy, but also around delivery. Okay, so because even if you have this in the policy document, how is it going to translate into action on the ground? And who's going to do it? So these are the lack of implementation mechanisms and, of course, the funding mechanisms. If there isn't investment in this, no matter how nice the policy documents look, if there isn't resourcing of this, it will not actually be translated into action. So the incentives for that. So we looked then to see, well, what if these are the barriers, these are some of the barriers, I'm sure you could think of others. What are the kind of enablers that can address these? So we felt that in terms of the conceptual barriers, there is clearly a need for much more effective advocacy for health promotion, to clearly communicate its purpose, to raise its visibility at a policy and at public level. And if we can do that, if there's a greater understanding of this, and essentially you're creating a public demand for this, well, then you have a strong justification for policy implementation and for keeping it high on the health agenda. In terms of the policy and political requirements, high-level political commitment is really essential, and be that at the level, for example, in some countries, of having ministerial responsibility for health promotion. In my own country, in Ireland, we have a minister for health promotion. So that person is responsible for arguing for the budget and for reporting on results. So that makes a difference if someone has that. Establishing institutional structures and processes that will support policy change, developing capacity and delivery mechanisms for actual implementation, how this is going to be rolled out at the regional and local level. Developing workforce capacity, looking at, we're saying that we require a multidisciplinary knowledge and skill base. Well, we have to then develop that capacity, and we have already invested some work in this in terms of identifying core competencies for health promotion at the European level, and also looking at it, there's an international accreditation system for this to try and increase and improve the kind of quality assurance around what goes under the headings of health promotion, because it's not an umbrella term for everything. It is actually has a defined set of competency skills. The need to invest in health promotion research and evaluation, because we need the research, obviously, around how this works, where it works, when, and also innovation around how we do that, because we're often dealing with multi-level strategies and approaches. And then the strong argument for sustainable financing, ensuring that there are, that the financing mechanisms are solid, that there's a commitment to it, and that they are protected. So that is the big challenge there. So these are, and in relation to the financing, I suppose I'll talk a little bit more about that in a moment. So they were the barriers and enablers. So after we had kind of gone through that critical reflection, we then said, well, let's look at some of the mechanisms for strengthening. And this was the final section of the report before we came to the recommendation. So what are the mechanisms that we know are there and are being applied and can strengthen health promotion within health systems? So firstly, we looked at implementing a health in all policies approach, which is essentially about promoting coherent policy across sectors to enhance population health, well-being and equity. And we can only do that when we work across sectors. It's not just within the health sector. And that's ensuring that there is capacity and competence within the health system to do this, not just working within health, but talking across government departments and wider community. There's a need for permanent structures that will enable sustained work, because this is the long-term investment. We need to have intersectoral committees at intergovernmental level, and we need to ensure that the processes and mechanisms are systematic. That is really key. And in the document, we present on lessons from Finland in terms of implementing this in practice and what they have seen to be helpful, and also Wales and Australia, some examples included there. And what they're saying to us is this requires long-term commitment and vision at a political and policy level, but it also requires permanent and systematic structures, processes and tools, and some of those are being developed. So every country doesn't have to reinvent the wheel here, but the structures have to be appropriate to the local context. So that was, and there's obviously more detail on that in the opinion. And these were some of the key components which, based on Timo Stahl's work, that were identified. Very important is monitoring, evaluating and reporting, because we have to constantly look and see, is this working, where. Framing planned action, having supportive organisational structures, ensuring that the needs and priorities are initially identified, and they look at kind of consultative mechanisms at a country level around this. So it's, really engaging wider community and capacity building. Okay. Next, we went on to look at health promoting health services, because when we looked at the papers that had reported on progress since Ottawa, this was the area where the most probably least progress had taken place. Our health systems have not really reoriented to integrate health promotion in the way that maybe was intended or could have happened. And I know this was of particular interest in terms of the mandate. So we looked here at some of initiatives that have been successful in this space. So, for example, the WHO Health Promoting Hospitals Initiative, which is an international network of health promoting hospitals. And we looked at, well, maybe what made this kind of successful. And some of it was the fact that, yes, there was an international network that was active. There were coordinators in countries. There were standards set. There was monitoring and evaluation, and there were indicators, and that helps to make it structured. And you can monitor and see what's going on. Likewise, the Baby Friendly Hospitals Initiative follows a similar sort of, so maybe, looking at that, maybe looking at the models there in terms of what contributed to making that successful. We also looked at the area of health promotion services for older people, where there is a huge scope, I think, here for greater integration of health promotion, be it in terms of community based services, intergenerational work, or indeed in terms of long-term residential and social care, incorporating a health promotion model, including a health promotion model of social care, could really be quite, there's a lot of scope for development in that, but we have very few real examples of it. Opportunistic health promotion within acute services, where of course time is quite limited and of the essence, but again we have initiatives like making every contact count, so that questions are asked in the course of a consultation regarding health promotion, because people at that time are very sensitized towards their health, and there really is an opportunity to say, have you thought about your exercise, diet, your smoking, your well-being, your stress, your goals, and also then finally in that section we looked at the fact that education and training of health professionals needs to include health promotion in the undergraduate curriculum, because if you don't learn about it there, it's not going to really be important to you when you come into practice. And there's actually been limited progress in that, because those curriculum, as you know, they're stuffed full, and it's very difficult to get some extra hours in there. But that's where it's the kind of pre-service training as well as the in-service education and training. Then we went to the area of primary care, and Jan and his colleague Dion contributed to this. And here, of course, the whole notion of a comprehensive and integrated spectrum of primary care is not new. It was there from Alma Ata and has again been reinforced in the Astana Declaration. And again, on universal health coverage, that notion that there is promotion and prevention alongside treatment and recovery. This is the continuum. In that we looked at how primary care is so well positioned to have a role in improving health literacy, and this is moving beyond functional health literacy. It's not just about patients being able to read prescriptions and follow instructions. It's critical health literacy, being able to appraise information, being able to then apply that information in the context of their lives. But it's also about the primary care and professionals engaging in that process of making the organisation more health literate, changing the way you interact. So here we looked at enhancing communication and shared decision making, and how important that is, and making services more accessible for people. So the health literacy has to go two ways. Also looked at health promotion interventions in primary care, and while we have reasonably good outcomes from brief interventions, when we look at lifestyle counselling and other issues, the actual evidence is not good there. Actually, it's weak in terms of the impact, particularly for people at lower risk. So it's saying that you need to move beyond that. You need to go and look at people's social and living environments, and so therefore we broaden then to community-oriented primary care, and we got some lovely examples from primary healthcare practices here in Belgium regarding that outreach into community resources. So again, it's going back to the socio-ecological approach. Where are people living their lives? Because that's where health is created and damaged. And so it's linking back into that, and also reaching out into more vulnerable members of the community. And so community primary care is very well placed as the first point of contact, located within the social milieu of their client group. So it's really in a very critical position to kind of do that kind of work. And we also reference some of the work around social prescribing, the prescribing of non-medical sources of support and resources based on people's needs. And of course also then the importance of advocacy and the important role that primary care can play in terms of advocacy for health promotion within that community setting. Okay, also the integration, we talked about the kind of trends in terms of public health and primary care within that concept of primary care zones working together more closely. And there clearly is an opportunity for health promotion also to be more integrated within that, and with social care as well, so that you can see from a community perspective, it makes sense that these kind of work together in a more joined up fashion. Coming to sustainable financing, and here the health economists in the group contributed to our deliberations on this section. It's clear that with health promotion there are low levels of spending despite evidence of cost effectiveness. And we look, their evidence is there on cost effectiveness, but that's obviously not enough to look at improved and sustained levels of financing. It's less than 3% in most countries, the OECD tell us, but I would suggest it's less than 1% in a lot of countries actually. And the explanations for why this might be, of course, there is the issue of timing. When you invest in health promotion, there is a time lag because the effects can be more long-term. And so there's a bias maybe in terms of having, closer and shorter term effects. There's also, I suppose, uncertainty that there's often a lack of clear and visible link between investment and outcome. So if you have programs in schools that lead to long-term improved health in adulthood, that's a causal pathway, and so it's more difficult to see it. Now, that's not always the case. Sometimes in health promotion, there are proximal short-term outcomes that we can monitor. But of course, making that more visible is actually quite important to the argument here. And payment mechanisms need to obviously then try to clearly identify what are the tangible benefits and the assets from health promotion, because the more tangible you make those, the more important they will be. And also, they also talked about the importance of creating a sense of entitlement. So if budgets in health promotion are cut, we're unlikely to see protests in the street. If you cut hospital beds, you will see that. So what are people losing? So when we say, what are you gaining from health promotion? And if you take away the funding, well, what are you losing? So that seems to be quite an important element to this, that there's a sense of real and tangible entitlement around it. So establishing mechanisms to set the overall level of funding and, very importantly, to protect that into the future. So these could be legal mechanisms, they can be laws. Payment system itself builds it in, that they can be reporting contracts, be that on a medium or short term, and then that they're, very importantly, there's a sense of citizen entitlement. And we look then at different sources of funding and different innovative models of paying for health promotion. And there is the phenomenon of health promotion foundations, which are of course funded from taxes on tobacco and alcohol and other what are called the sin taxes in different countries around the world. And while these work, the issue is, I suppose, the more successful you are, the lower your budget will become. so there is a bit of a problem with that model. And then there are there's earmarked funding, delegated financing and budgeting schemes. But the issue seems to be what protective mechanisms can you put in there to make the budget sustainable? So you've got to set the overall level and then look to protect that into the future. And then we come to the section on mobilising community participant engagement, which our colleague Luba, sitting at the back here, also contributed. And this recognises, of course, that we're talking about a whole of society approach here, engaging civil society organisations, non-state actors, particularly if we're looking at a cross-sectoral approach. This is really important, that there's a wider community engagement. And really important for policy development that's inclusive, and implementation processes that are inclusive. Here, the focus here is on how people can be empowered to engage with this, and also empowered to demand action. I think that's quite important. And working in partnership effectively, building trust, dialogue, synergy in terms of different agendas. So community development and asset-based approaches, working with local community structures. The issue of cultural competence, of course, is incredibly important here when we talk about community working. The power sharing, collaborative decision-making and partnerships, and working with bicultural workers if that's appropriate, because when we're engaging, with diverse communities, that really has to be on the agenda. Very important also around mobilising community participation is reaching out to those more vulnerable groups, and also younger people, engaging younger people around health and health issues. So using diverse methods and of course new technologies to reach people. And there's a lot more that can be done in relation to this. So I think that brought us to our conclusions. So coming towards the end. And our conclusions are that there is a solid case for investing in health promotion, be it on the grounds that it improves population health and well-being, that it reduces inequities in health, it protects human rights, and also that it improves the performance of health system in terms of making them more sustainable. The implementation of the SDGs in Europe and the focus on universal health coverage gives a new impetus for concerted action around health promotion. I think it's time that we move beyond the rhetoric, because the rhetoric isn't contested in many ways, but strengthening systems and capacities for implementation. So that's where we need to, is the implementation and making it real. Integrating health promotion more effectively within our health systems in terms of strengthening the health promotion functions. And I think this needs to be done at the broader political and policy level, as advocated by a health in all policies approaches. So we need a comprehensive approach to this. There aren't quick fixes. I think there needs to be a strategic commitment to it. So coming to the recommendations then, we suggest that there's a need for advocacy for the importance of health promotion for sustainable health systems. So making sure that what health promotion is about is understood across the political spectrum, and also in communications for public health. To make that, give it more prominence and communicate this clearly, and especially for vulnerable groups. Advancing political commitment for effective policies and action plans. And here, looking at high-level policymakers, both at the EU level and at the country level, to take on board just what is the balance of spending across the spectrum of health services, reviewing that, and balancing spending in terms of treatment and rehabilitation with promotion and prevention in a more realistic way. Investing in the development of robust policies and programmes at EU level, so that we see kind of a sustained kind of investment in a comprehensive approach beyond once-off and standalone initiatives. Developing capacity to implement at EU and member state level, and here looking at guidelines and standards regarding governance structures and processes. What needs to be in place? What level of leadership is necessary for this, and political responsibility at the country level. Strategic leadership is very important in terms of strengthening promoting health systems, and so making sure that it's integrated across European and national policies, not only in health but in other social policies as well, because it can fit quite well across that spectrum. Providing technical guidance on implementation in practice, because supporting countries around setting norms and standards for best practice, and also priority interventions, so that each country doesn't have to start at the beginning, as it were. Promoting the integration within health services, which we spoke about, and particularly primary care. We can see how important that is, because universal access to health promotion will increase the scope and reach of those services, particularly for underserved groups. Supporting the assessment of health promotion capacity in member states, and this is where we can look and benchmark countries, like what policy and implementation structures are in place. So making it an assessment of that. What's missing? Where are the gaps? What needs to be strengthened? The need to invest in a dedicated workforce. Again, we have talked about that earlier. And I think there's important leadership at European level needed in recognition of the fact that a dedicated health promotion workforce that has the right set of skills and competencies for quality professional practice on this. I think that's really important. for effective delivery. Investing in research, innovative interdisciplinary approaches, and we've listed some of those. For example, monitoring positive indicators of population health and well-being at a country level, not just monitoring our outcomes in terms of mortality and morbidity, but in terms of positive health and well-being. There can we see the impact. Comprehensive evaluation, because many of our health promotion interventions are complex and they're multi-level, and our existing methodologies are not well designed and well suited to cope with that complexity, be it, whole school approaches, whole workplace approaches. Multi-country implementation trials. We have, a real systematic focus on implementation research, taking it from the evidence into, and does it work across different settings and contexts? Economic analysis of our health promotion intervention so that we can improve, the whole kind of dialogue and debate around that. And dissemination of feasible evidence-based approaches that have been shown to work. Critical to this also is knowledge translation mechanisms. And that is, I think many countries have invested in knowledge translation strategies and approaches, Australia, Canada in particular around public health, but maybe doing that at the European level. So we've more effective take-up and use of research and knowledge, and a better two-way dialogue from three-way, practice, policy and research around this, so that evidence is more usable and the wisdom from practice comes back into the evidence as well. So we need to look at dedicated centres for that. Strengthening our partnerships at EU level so that there is a kind of an active engagement of key players and actors, be that in terms of NGOs like IUHPE, EuroHealthNet, academic partners who are working in this space, and national focal points, because getting that dialogue across countries so that there is learning going on and a sharing of experience and knowledge. And finally, supporting social mobilisation strategies, improving the broad level of community engagement and how that engagement process is undertaken so that we can promote greater public awareness and understanding, and that there is an appreciation of what health promotion has to offer in terms of sustainable human, social and economic development. Why is it important? And greater accountability at EU and country level. So we've reached the end. So thank you very much for listening, and I think we have time for comments, questions and answers. Thank you.
Thank you very much, Margaret, for this wonderful talk. I think everything that could ever be said about health promotion is in this document. Thank you so much. In the meantime, also another member of our group arrived, which is Muraskiene Ljuba from Vilnius, and please join us here up front. And she mainly worked on the issue of the community aspect in the document, as was already said by Margaret. And by the way, we also welcome from DG Sante, Nicolene Tamsma, Dumitrescu Ovidiu, and Volosinova Vieira. So that's the team, and of course our trainee as well. So the floor is now open for discussion. The idea is not to say, well, you are right or you are wrong, but to give feedback on the content and to suggest improvements. The broader debate on the content can then be given once we have the final draft edited. So your feedback now comes to help us to improve the document and to deal with things that are not well explained, or omissions and other kinds of things. As I said already, present yourself when you intervene. Speak into the microphone. This is a kind of family meeting, but nevertheless we need a microphone because of our remote participants that have to be able to follow us. So then comes the most difficult question of this morning, and who is going to make the first comment? Yes, please. Present yourself and...
Hi, Emma Woodford from the European Oncology Nursing Society.
Stand up,
Do you want me
please.
to stand up?
Yes, that's better.
Well, thanks for the opportunity to ask the question. Coming from the healthcare professional perspective, we very much like to see the better call for education and capabilities in the multidisciplinary teams, and the fact that health, throughout the document, healthcare workers are called healthcare professionals. I think that's very much appreciated. However, there are a lot of prevention activities going on already, especially amongst the oncology nursing community. We have members operative in hospitals, in communities, and also in primary care settings, working on tobacco control projects, working on giving advice to people in communities on alcohol prevention programs. So I think, you know, the phrase developing the capacity for healthcare professionals is a bit limited. I think we need to be looking at what is already out there, harnessing the experience of these healthcare professionals, identifying the change makers and using them to inspire others. And I'll send some more detailed notes in a written feedback. Thanks.
Thank you very much for this comment. You want to join on the same topic and then we reflect from here, or is it a new topic you want to?
It's a new topic.
A new topic. So then maybe let's have a short reflection on this. I think this is very worthwhile contribution.
Yeah, thank you for raising that. And yes, indeed, of course, there is a lot of prevention activities included within healthcare workers. I think that the point we are making here as well is that in addition, we also need to see health promotion outside of the healthcare setting as well. It's really crucially important in community settings, schools, workplaces, homes. So there is a need also in terms of the promotion element as well as prevention, primary, secondary, tertiary prevention within healthcare. So we see it as a spectrum and all is needed. So I hope that clarifies. So we're saying we need the promotion as well as the prevention. And of course, there is key activities by health professionals that contribute to this and are really important to reinforce and to strengthen.
I can send you some examples
Yeah,
of where
please.
healthcare professionals in communities already
Yeah.
doing it.
Yeah, please do. Yeah.
Will be very much welcome because that makes it more concrete. And of course, we are very happy also that you mentioned the issue of education of health professionals, preparing them for the future. And I just want to remind you that we published some months ago a document, an opinion on task shifting, where we dealt in depth with the issue of education, profiles, complementarity, and this kind of issues. And of course, this applies for sure also to the field of health promotion. So thanks for reminding us. Please, next intervention. Microphone's coming.
Yes, thank you. My name is Dorota Sienkiewicz and I work for EuroHealthNet, so one of the two organizations mentioned in the slide and the opinion. So thank you very much, although I think it's a joint work done by many organizations across Europe. Thank you very much for the draft opinion that we've looked in, but we didn't manage to go to the end in the space of time that between it was published and today. So we will also submit a written response or contribution where we will try to provide a kind of more detailed account. Just a couple of things. If I could ask here for like better clarification or just to kind of add to the discussion. We feel the opinion is a little bit too much maybe for the moment still resting on the UN, so the very much WHO and UN approaches, so kind of maybe a better link to the really like EU policies, and not only within the health sector but also other policies that are there, and really actually linking to the treaty on the functioning of the EU, the Article 168. I mean, you've mentioned the health in all policies approach several times, but if this could be even put up front that there is a legal basis for that already, and so that it's more better enforced, etc. Other things that we think could definitely add to the opinion is you talk about health literacy as a way to transform or deliver the health promoting health systems. The digital health literacy is very important as well, since we see the pace of the digital transformation of health and society in general. I mean, you mentioned linking the fact to the education sector, so that other sectors take responsibility. A lot is happening already at the EU level within, for example, the economy of well-being approaches, and the European semester, the implementation of the European Pillar of Social Rights, the next EU budget. So we will try to provide a written contribution in relation to that, because a lot of financial, technical assistance is already there that could help transit the health systems and other systems towards being more health promoting. And another thing, sorry, the last thing, just to add, EuroHealthNet has recently published a financing guide on, it wasn't mentioned yet, I think, because it was a kind of coinciding around the same time. So a lot of things and ideas also there on innovative ways and mechanisms to search for financing to add. Yeah, thank you.
Great.
Thank you very much. Margaret, please.
I'm aware of the financing guide. It came out just as we were nearing the end of the report, so there's an opportunity to reference it in the final version, and I would welcome your inputs on the issues that you mentioned, and as soon as you can, because we need to complete this report within the next couple of weeks, I think. So
Yes, the panel will decide upon the final version in its meeting on the 7th of November, which is, of course, nearby.
So it would be great to have your input on that. Thank you.
Yeah. Thank you also for mentioning the issue of digital health literacy.
Yes.
I just want to remind you that we recently published an opinion on digitalization,
That's right,
where this issue was mentioned, but I think we should cross-reference this also to this text.
It's mentioned briefly, but it's not. Yes. We can strengthen that reference. Yeah.
And of course, stimulating us to have a kind of integrated vision, taking elements from EU policies, UN, WHO approaches, I think, is absolutely in the DNA of this panel. And I think you very correctly mentioned the opportunities to improve that aspect, clearly. Okay. Other reflections, questions, please. Present yourself and take the floor.
Thank you very much. My name is Martina Glieber. I work at Institut Mérieux. It's a health industry company based in France. I have a background in health promotion and health management from a German university in Magdeburg. And I'm also finalizing a training in sophrology, that is a body-brain intervention, psychocorporal approach for stress reduction. So I wanted to make 3 points. So the first one is health literacy. We think that this is really important to better inform, and with a global approach, not only a few happy ones, but really access to all about a healthy lifestyle and impact on diseases. Share evidence really broadly, also with maybe disadvantaged populations. And inform also about the impact, for example, of inappropriate antibiotic intake. The issue about antimicrobial resistance is very important, and there are so many people that are still not aware about the inappropriate intake of antibiotics. The second one is healthy food and the environmental approach and the policy around that. I think we will more and more move towards a kind of a personalized nutrition approach and integrate all these healthy food aspects also in not only in health promotion prevention, but also from a treatment approach. I think this is health promoting activities, I think, certainly are focused on healthy population, but I think our health promoting activities should go more and more also into the health care domain and help the people to get, again, improved health and not only to stay healthy. I think that is important. And the third one is around stress. You mentioned the chapter about mental well-being, and I think this is really important. And we have not enough shown the evidence about stress on diseases, on chronic diseases, but also infectious diseases, and what to do in order to help people individually to reduce the stress. I do not only say that because I'm trained in this kind of body-brain interventions, but we are trying it now at the workplace. Our company has 17,000 employees all over the world, and we try to help them really to provide these approaches with health-promoting activities at the workplace. And there are very positive impacts now already, and the people really say that they need to get help in managing their stress, their emotions, and it's a kind of individual empowerment to stay healthy, but really also to manage pain. The stress component and anxiety regarding to pain is very important. So I think all around stress is maybe something you could highlight a little bit more within the chapter of mental well-being. And then I would also say that there could be a little bit more link to the European instruments and initiatives, especially the importance about evidence generation, and maybe there a link to Horizon Europe that is currently being prepared, the new framework program for health and innovation of the European Union. So inside there are health partnerships, where we would like, at least with FPR, COSIR, we are discussing future health partnership, and we think there is a room for including health promotion more and more, together with a health, more medical approach, but have a cross-cutting approach. There are the missions on soil health when we talk about nutrition. There's a mission about soil health and food. There is a mission about cancer, where I think health promotion should be more included, and also in other work programs of Horizon Europe. And then we have the health program from DJ Sante, where there could be initiatives like joint action on health promotion. I'm not sure if that exists already, but I think recommendations on these kind of initiatives could be interesting in your report. And maybe also the European Investment Bank. I don't know if there could be some incentives for companies in order to provide health promoting activities at the workplace. I think it's a lot around incentives. It's also a lot around reimbursement. These kind of activities for the moment are not yet reimbursed, even if they can have a huge impact. So probably we need to first show the impact they can provide, and then work towards new models of reimbursement. I think this is really important. And all that in an integrated cross-cutting approach. So really try to integrate health promotion also into the whole care pathway, and maybe demonstrate also better treatment outcomes. Thank you.
Thank you for this contribution that mainly helps us to become more precise in illustrating the principles and the concepts that are put forward in the opinion. Margaret, do you have to, I think most of those things are that you mentioned are straightforward and are worthwhile mentioning.
Yeah. And in relation to the stress in the workplace, there's quite a bit of evidence already there, but particularly around not just individual, improved stress management, but also around whole organizational approaches. And it's when you get those individual and organizational approaches working together. And of course, the Health and Safety Directive includes that whole issue of psychosocial hazards in the workplace, and how important that is, so that there is a growing evidence base around what makes that work.
Okay. Yes, I see a lot of reactions all over the place. Maybe we start there and then we go that way, and then yes, please. Present yourself, stand up and speak clearly. Thank you.
My name is Maura Lusignani. I am an associate professor in nursing sciences at the University of Milan, and I represent the Italian National Federation of Nurses. We appreciated in your document many important key points. First, the need for a health conceptual framework, including the Sustainable Development Goal. This is a very important content for education and practice, of course. The progress that have been made in the application in practice of this new approach, the evidence that showed the efficacy of health promotion, and the need for both advocacy and political action and sustainable financing for health promotion, considering the lack of investment in developing the necessary health promotion system. Moreover, we agreed when you said foster health, promoting health system calls for a new base of multidisciplinary knowledge, skill, competencies that extend beyond the traditional healthcare approach. This requires a broader understanding, you said, of health and its determinants, yes, of course, and an advanced recognition of a dedicated health promotion workforce. You said, and we agreed, that a cadre of health promotion specialists are required with the necessary training and competencies to implement effective programs and policies and work with the wider workforce to ensure sustainable action. These challenges imply both the organizational and workforce capacity development, you said, and the academic capacity to meet the new population needs. In the document, however, despite the agreeable premises and analysis, unfortunately, we didn't find a line dedicated to the importance of the nurse's role in health promotion. And in this case, we are talking about, in the EU, almost 4 million nurses, and in Italy, 400,000 nurses. You dedicate a paragraph, of course, for health promotion, education, and training for health professionals, but referred only to medical education. We would have liked you to have mentioned the role of nurses in health promotion. We think, of course, that nurses play a critical role in providing healthcare, not only in hospital and long-term care institutions, but increasingly also in primary care and in home care setting, for which there is robust evidence as to their impact in improving health outcome in multiple domains. As we said, a growing number of nurses also work in primary care in many countries in response to the two shortages of general practitioners. Some countries have introduced or extended advanced role for nurses to improve access to primary care. Evaluation of this experience with advanced nurse practitioners in countries like Finland and the United Kingdom indicate that these nurses can improve access to care and reduce waiting times while providing the same quality of care as doctor for a range of patients, for example, with those with minor illnesses or requiring routine follow-up. The impact of nurse-led clinics in relation to patient outcome, patient satisfaction, impact on patient access to services, and cost effectiveness has been demonstrated in the literature. The most important outcome found were, for example, patient self-reported improved symptom management or health, feeling of improved general health and well-being, and specific improvement in chronic obstructive pulmonary disease symptoms and in the healing time of ulcers, improved body mass index standard deviation score in obese children, and treatment regime for upper respiratory tract infection, or in the improvement of medication adherence. Of course, there are examples, only examples. Advanced practice nurses in this situation were integrated, of course, with multidisciplinary teams, and the main intervention deployed were patient education, multidimensional assessments, and coordination for multiple providers. In the EU and also in our country, a core curriculum for postgraduate level training in health promotion based on core competencies has been implemented, but further investment is required in this field. Finally, in your conclusion and recommendation, you confirm what we have been saying. We need more investment both in academic education and in practice to develop dedicated workforce for health promotion in Europe, ensuring they have the necessary knowledge, skills, competencies to strengthen their role in the health system and promote their professional identity and responsibility. And we agree with this conclusion and ask for the mention of the role of nurses in health promotion and for the improvement of advanced nursing education at the master degree level, for example, in the family and community nurse or in the nurse in public health or in other specialistic sectors. Thank you for your kind attention, and I hope this hearing has been useful for you.
Thank you.
Thank you very much for making this point. We have clearly seen that some of the dimensions nurses contribute to are, from your point of view, not sufficiently explicit in the document, and we will look to see how we can do that. However, that have been said, the approach from the panel has always been the emphasis on an interprofessional, integrated approach by a team, be it at primary care level, be it in hospital level, be it in public health approaches. And that's also what we emphasized in a lot of our other opinions that we made. And of course, quantitatively and qualitatively, nurses play an important role at all these levels and have a diversified appearance nowadays with people that are doing independent consultations, that are involved in specific disease-oriented programs, or that grassroots working in strengthening the difficult-to-reach groups and informing them about health and related issues. Yeah, so the point has been clearly taken, and we appreciate, of course, the appreciation that you clearly echoed in your intervention towards the work we have done. Thanks for that. The next speaker, also somebody from our fan club. Well, re-welcome.
Good morning, and thank you very much for organizing this hearing and for the comprehensive presentation. My name is Antonio Grasso from the PGU, the Community Pharmacist organization at European level. We represent community pharmacists from 32 European countries. So, of course, we welcome very much your presentation and the content of the paper, referencing to the important services of healthcare professionals in general as being helpful in promoting health in communities. And we also welcome your recommendation, also quoting the OECD finding that only 3% of healthcare budget is invested in health promotions, which is something that is circulating around from the State of Health in the EU initiative since a couple of years ago, but we still find that there has not been a much improvement in terms of managing finances at member state level and increasing the share of investments in promotion. So we join you in advocating for increasing resources in this field. And of course, when it comes to promoting health, to reducing health inequalities, to improving the gap that exists between people with different social backgrounds in accessing healthcare services, community pharmacies play a key role in Europe, because we are the most accessible point of healthcare systems across Europe. We are present, we are often the only healthcare facility present in rural areas in Europe, where most likely vulnerable groups are resident, and therefore we provide health services that promote health and that are increasingly going beyond the poor medicine supply, but include also early screening of diseases and immunization services, as well as contribute to improving health literacy in patients, since we provide free advice on uptake of medication and more specific services around medicine use review and uptake of new medicines by the patients. We also welcome your call to increase funding for health promotion research, because we have our services have been evaluated at economic level from an academic point of view, and they have been proven to be cost-effective and also improving clinical outcome in patients. And therefore, we promote if this is uptaken by institution when doing their recommendation to the member states. We would also welcome to include and link the call for increasing investment in health promotion to some key European initiatives such as the European semester, where member states are often confronted with budget pressure, with measures and recommendations related to budget pressure, but we should not forget that health promotion can be something that will bring also benefit in terms of public finances in the future. And then, last but not least, we would welcome, if possible, the reference to also community pharmacy services in your paper within the framework that we understand very well of an integrated care approach, and that we also support. And in that respect, we would welcome the possibility to send you some written comment and references to our studies. Thank you.
Thank you very much for sharing a lot of the aims and goals that are formulated in this document, and also for putting our attention on the need that this requires translation into European instruments. I think that's an important issue that comes up, and of course supporting the teamwork approach, where the role of the community pharmacists, as you explained clearly, becomes increasingly important. And in many countries we really see a shift in the profile of the community pharmacists from just dispensing medication to become a health agent in the society, what you also mentioned very clearly. So I think that is very valuable, and it illustrates the importance of this document to be translated into the perspectives and the practice of different disciplines in the framework of our interprofessional approach. Thank you. Next intervention. Yes, please present yourself. And
yes, my name is Wouter Arazola Dioniati. I'm a medical doctor in public health and now working for the Belgian Lung and Tuberculosis Association, so air pollution, tobacco, and tuberculosis. From the tuberculosis sector, I would like to say, of course, that it's one of the diseases that strongly linked with social determinants. So go and talk with the tuberculosis associations because they have a lot of experience. We have been working for 110 years here in Brussels with outreach, with community health involvement, with culture-sensitive ways of working. That's one. Professor, you mentioned indeed vested interests, and I would suggest to elaborate a little bit more on the commercial determinants of health and the inappropriate interference of industries with conflicts of interest into policy making, using fake science, lies, lobbying, buying scientists. Because we have a health promotion, we can have a health promotion sector that's really strong. If we don't handle the commercial determinants, we're not going to reach as far as we wish. So how to deal with the power imbalance between the extremely rich and powerful corporations and health policies?
Thank you very much for this point, and I think the word commercial determinants came up in our discussions when we discussed this document very clearly.
We have included a section on addressing the commercial determinants and spoke a little bit about the nature of that in terms of the interference. We have strengthened a paragraph on that. And you talk about the power imbalance as well. And I mean, clearly what we can see from tobacco is where you assert the right of countries to protect the health of their population and you put a legal framework around it. I mean, this is obviously the ideal. I mean, that's how we shifted the debate on smoking and moved it along. And clearly, if you have a kind of legal and regulatory framework from the top, that strengthens, as well as a support that people wanted, and so now that has to be done across the diverse commercial determinants that are there. So I mean, I think that process, there's an awareness of that, and it's starting to be addressed through and again, it's worth saying that the WHO framework on tobacco control was very much up and down the Ottawa Charter. It used integrated actions, and I think this is this to me seems what we have to do across these areas in terms of unhealthy products and their marketing. Yeah.
And also when it comes to, fake information,
yeah.
We dealt with it especially in our the opinion on vaccination, and where there's an important chapter on vaccination hesitance and the different components. And it is true, and media increasingly pay attention to this, that we don't have only to promote the good things, but that more and more you also have to make sure that there are not disinformation strategies that reach people and that are dominated by all kinds of interests that are not really the health of the people and the individuals. So, and that's the playing field we are in today.
And I think we have to look very carefully at who is sponsoring and supporting work in different areas. Who are they? Because it's not always immediately clear.
Yes. And that's why the conflicts of interests of all the panel members are on the website. You can see what we are all doing in different fields. Good. This transparency, I think, is absolutely required because it's a precondition to have an open debate. Exactly. And of course, power imbalance is also an important issue that you mentioned. And thanks for reminding us that there is still tuberculosis as an indicator that we still did not achieve our goals when it comes to social determinants of health. Yeah, after more than a century. Yes, the next intervention, please. Yes, please.
Yeah. Thank you very much. My name is Thomas Alvin from FBA, the European Federation of Pharmaceutical Industries Associations, representing the research-based pharmaceutical industry in Europe. Thank you very much for this report and for this opportunity to comment. And I think that and it was reflected by some earlier comments. I think, with the developments in science and digital health, etc. I think we see more and more the old boundaries between sort of prevention and treatment, etc., is starting to blur and becoming more of a continuum, which I think is very exciting, with a lot of opportunities there. Just three main points, really. The first being on budgets and financing, which I think is really important. And you mentioned in the report this 3% figure from the OECD, and but which of course is related to sort of classic public health and prevention. But I think also if we see health promotion, as you do in the report, in the broader perspective of health in all policies, and you start to look at what's the role of other sectors, transport, clean cities, environment, housing, all these things, then you potentially get a lot more budget to play with if you can make these sectors work for health. And I think that's also something, us in the health sector should think about more, how to look beyond and actually use those instruments to achieve health goals, and also looking just within the health system. And you mentioned the sort of the balance of spending. I think it again illustrates a wider issue also in more classic healthcare, when you have the different budgets in healthcare that doesn't always work in towards a joint goal. And we take something just simple like, we all know that more investment in primary care to manage chronic diseases will avoid unnecessary spending and hospitalization and emergency care. But still, when these are different budgets, it's very difficult to get that investment to happen. And I think
Yeah.
maybe some good practices in this area from different countries would be interesting to highlight. The second point is more on kind of personal empowerment, and I think going back to the comment earlier on digital health literacy, where I think there's so much happening when it comes to things like personal health apps, wellness apps, all these things. There's an explosion in this area, empowering people to kind of take control over their own health. So some of this might be very good. We don't know everything that's out there. Of course, is very much bottom up rather than top down in many cases. But I think this is interesting to explore and maybe elaborate a bit more on. And I think one important point there that I think could be highlighted is the sort of the right for the not only patient but the citizen to access his or own health data and electronic health records as a way to getting getting that empowerment over one's own health. And I think also you mentioned the role of social media when it comes to young people. I think today it's not only young people either. I'm on social media. I'm not that young anymore, unfortunately. So I think this is a huge future perspective that I think really needs to be highlighted. And then just on a final point, and some people already mentioned, how to tie it to existing EU instruments, which I think is a good idea. And I think also, there's quite a few recommendations in the report, and of course there's always a risk when you have a long list of recommendations that none of them gets done. So maybe if you've thought about, I don't know, structuring them or prioritizing, and also think about what can the EU do versus the member states, and where can the European Union add value through different actions and instruments. Thank you.
Thank you very much for mentioning these important points, and already you gave clearly indications to which of the components of the opinion they speak to, and also re-emphasizing the importance of stressing more explicitly what EU instruments can do in that field. In that respect also, I invite you to have a look at the brainstorming paper that we published on our website in April. Was not an opinion, and where some brainstorming ideas came up from the panel members to inspire future developments. And just because you mentioned this balance of spending when countries want to move from hospital-based care to primary care, of course confronts countries and member states with the difficulty that you at a certain moment in time you need to double financing, because you still have your hospital and you have to strengthen your primary care. One of the suggestions the panel made was that could typically be something where Europe could help member states in providing this transition within a framework of clearly set goals, because otherwise you see that countries and member states don't take the hurdle, because it's too difficult in these days to say, well, let's go for a double spending, if the single spending becomes even problematic in many countries, as I see in the budget discussions in members in a lot of member states today when it comes to health. Yes, please. Can you speak?
Okay, thank you. Coming back to this 3%, the difficulties to calculate money for the broader approach reveals the problem that there is a lack of systematic approach. So it's just you couldn't easily calculate money for something not very well defined. It's a point as well.
Yeah, that's of course that's the problem with intersectoral action, is that you have this kind of, also intersectoral budgets, and most of the budgets in most of the countries are siloed. It's either traffic or housing or health. And with this approach, as we mentioned very clearly and Margaret illustrated, you go transsectorally, and then, as Yuba said, it's very difficult to identify budgets, but at least being aware of these mechanisms is a first step to make them much more clear and to emphasize them also. So thanks for this suggestion, clearly. Other interventions, please. This has already been a highly participatory. What, do you want to have a short intervention? Yeah.
Maybe a good. I don't know the diplomatic sensitivities, but maybe a good partner could be the new director, regional director of WHO Europe, Hans Kluge, who is also very interested in health services and changes to the health services systems.
And of course, all our hopes are in the new commissioner, which is Stella Kyriakides for health, and has a background, I think, that is very promising. And not at least also in the new president, Ursula von der Leyen, who is a public health physician by training. So we hope in the future that there will be opportunities, and at least there are some interesting and very inspiring indicators that may create opportunities for the future. Okay, so I think that I can say on behalf of all of us that we are very grateful for this input. This is really helpful. If you want to send in some documents, please do it as soon as possible, because we are in a process. As you know, we end our second cycle, and then on the 8th of November, our existence as a panel ends. We, by the way, have a symposium then. So then there will be a new panel that will start, I think, in the beginning of next year. So that means that we have to finalize this document in our plenary meeting of the 7th of November. So send it as soon as possible, be as concise as possible. But already I think from this hearing, we have a clear idea on what are the points that require some reflection, but we also appreciate very much the overall positive feedback that came from all the interventions. So this is very encouraging for the work. I give the final floor to Margaret to wrap up a few things. And
thank you, Jan. Just very briefly, just to thank you all very much for your engagement. I've made notes on the comments that were made. We'll take these away and deliberate on them. And as Jan said, any further input gratefully received as soon as possible. So thank you very much indeed.
Thank you very much.